I am absolutely delighted to introduce Naga Chalasani, a good friend of the unit, an exceptional leader and physician scientist. But before I do, I want to say a few words. First of all, of thanks to Frank and Barbara Cleon and the Transplant Living Center for their undying support for our programs, for endowing this, and for just being great team players. So a round of applause. Couldn't do it without you. And also Jean, Im, and Lorraine, who really mastered a terrific program today. Thank you, guys. So let me say a few words about Fenton Schaffner. Every year I try to include something new, and I have something this year for those who remember. Fenton was the founding division chief of the Division of Liver Diseases, as Frank will attest to, knew much better than I did, and also Nancy Bach, who I think was his last trainee. I saw you there, Nancy. He didn't like to call it hepatology. I've never quite figured out why, but it was liver diseases. And he didn't get along terribly well with the guy who was becoming chief of GI, who was Henry Janowitz. And so in those days, there was no blueprint for how you divide up GI and liver, so they split it into two divisions, and it's been a merciful and blessed decision for me as division chief now for 18 years, because I've never thought about luminal GI or endoscopy since then, although that has its own challenges. But it's been an honor to be the successor to Fenton after Paul Burke. So think about it, since 1965, I'm only the third division chief. So we've had stability, if nothing else. So let me tell you a little bit about Fenton. This is a picture of Fenton Schaffner. He was the partner in crime of Hans Popper, who was perhaps better known. Hans was the founding dean and a pathologist. Fenton was really, and correct me at any point, Frank, because you were there, but Fenton was not only a superb hepatologist, really the first generation of true hepatologists in the United States. He was also, in his own right, a superb pathologist. As was Hans, they created, in part, our understanding of liver disease by what they saw under the microscope. Fenton was also an inveterate book collector, and these are some of his, this is the nameplate from his office, which his widow, Roseanne, gave to me, which I accepted on behalf of the unit. And in addition, he was a collector of ancient books or historical books about the liver, and what I'm about to introduce in a minute or two was that it wasn't that he just collected the books, he actually read them, and I'll tell you more about that in a minute. So for anybody who wants to come peruse these, I really encourage you. Books are there to be read, not to be looked at. And anytime we have a visitor in Naga, I apologize, I didn't give you a chance, but we were too engrossed. But these books by Virchow and Mallory and Charcot and so forth and so on. This is Hans and Fenton getting honorary degrees, and if you want to, and that's Hans, of course, and there's Fenton. If you want to know why the address of the medical school is Gustav Levy Place rather than Fifth Avenue or whatever, that's because of this guy, Gustav Levy, who was the founding chairman of, he was the chairman of Goldman Sachs, which probably had a lot to do with, he was also the chairman of the board of trustees, and was very generous and instrumental in generating the resources that led to the founding of his school. One of the things I always am reminded of when I was a student, and I knew Fenton, but not nearly as well as I said as his full-time trainees, but I fell in love with liver in second year of med school, and I sought out his guidance and asked him if he'd agree to be my advisor, which he happily did, and he was a wonderful resource for great advice. And among the many things that he advocated in an academic life was the ability to travel. And I always remember sitting in his office and seeing this framed photo of he and Hans having come back from a gold mine in Johannesburg. And I thought, well, maybe I won't make a lot of money, but I'll definitely, get the frequent flyer miles. And that's turned out to be pretty true on both counts. And it has been a blessing. And frankly, that seed in part was planted through Fenton, along with a lot of other sage advice that continues to influence my career. These are some of the essentials of his CV. Graduated from the University of Chicago. I think he was a native of the Midwest. Came here in 1958. Became chief as the division was established. So I guess we're going on our 51st year now. He was like 5 others, including me at Mount Sinai. He was president of AASLD, so there's been 6 AASLD presidents from our faculty. Needless to say, a prolific author, seminal papers, a revered clinician, teacher, and mentor. So what I wanted to add this year is a transcript of a lecture he gave that was provided to me by Barbara Niss, who is the institutional historian. So he had given a lecture on the history of liver disease that was so erudite and so detailed in terms of not only the ancient, but the medieval, the Renaissance, and the history of liver disease, that it was really stunning. It made me realize that he was a scholar in a way that I'll never be. So I have the transcript of that lecture. I'll leave it with you, Frank, so you can read it, but anybody who wants to read it, it's really a treat. But I thought there were 3 quotes that I pulled out that were especially pertinent. One is, he said at the beginning, I look upon myself as an evangelist more than anything else, trying to sell the liver around the world as something to be interested in, not only from the clinical point of view, but the investigative one as well. And an evangelist he was, and a traveler around the world he was, so he wisely combined both of those. Then he was talking about the 19th century. I thought this was very interesting. He started, with the Greeks and the Etruscans, but during the 19th century, there was again an attempt made at therapy, and there were 6 diseases that really people were trying to treat. One was a fatty liver, and in this way, this was recognized probably by Laennec as one of the early ones. And this is even where he got the word cirrhosis from, which just meant yellow, the yellow color of the fatty cirrhotic liver that he observed. But in addition, it was recognized that non-alcoholics could get yellow livers, although they were not as hard and obviously not cirrhotic. He was talking about NASH, basically, being described by Laennec in the 19th century, and we thought we were so smart, but obviously smarter folks preceded us. And then finally, and I love this, so much is continuing to go. He was talking about Mount Sinai, and he gave a very detailed history of liver disease at Mount Sinai, which had an illustrious history even before him. He said, so much is continuing to go on, and hopefully Sinai's name will continue as a center for making contributions to the study of liver disease. And I hope to be able to be part of this activity for a while to come yet, and I would like to invite some of the others to participate with it. So that's his legacy, and all of you who are here to a person are part of that legacy, and in his own way he foresaw that and he encouraged it, and ultimately we're living it. So that's really one of his legacies, and this is the other, of course, is there was a trainee reunion. I was privileged to be part of it. Here's Frank. You haven't aged a day, Frank. Here's Nancy, looks even younger now, and I am the geek on the right-hand side here with the brown glasses. So I could think of no better exemplar of what Fenton stood for and what our division has become than our guest today, the Fenton Schaffner lecturer, Naga Chalasani. Naga has been a good friend to the unit as a collaborator and as a thought leader, but his contributions are exceptional in many, many ways. He's a renowned clinician, a renowned teacher. He's trained dozens of outstanding leaders and continues to do so. He's been the division chief at the gastroenterology division at Indiana University, and during the course of his 13 years as a division chief, the division has grown from 26 to 70 full-time faculty. He has also been a national leader and international leader in several diseases, but most notably DILI, which he'll talk about today, or drug-induced liver injury. He's also a leader in the NASH Clinical Research Network, as well as the Alcoholic Hepatitis Clinical Research Network. He's widely regarded and funded. He's a member of the ASCI, the Association of American Physicians. He's certainly earned every accolade. And since 2013, he's also been the David Crabb Professor of Medicine. For those who don't know, David is really a contemporary of ours who was an outstanding scientist and physician, and is an outstanding physician scientist in his own right, and former chair of medicine. And so this is a man of extraordinary talent and also extraordinary humility. He listens, he's thoughtful, he's a fantastic colleague to have on advisory boards. And as I said, and Andrea can attest to this through some collaborations we started last year, he's a wonderful collaborator, extraordinarily generous, and an exceptional human being as well as a physician scientist. So with all that, welcome, Naga. We have a small token of our appreciation. Jean, you want to introduce us?
Yeah, sure. This is a liver. we gussied up a little bit this year, but we thought it's an appropriate gift to you in recognition of all your achievements. So
thank you so much.
You're welcome.
Well, thank you, Scott. That was a wonderful introduction. I'm quite touched. This is an incredible honor to be presenting here. This is the land of Hans Popper and you and Scott Friedman whom I looked up to. I consider myself sort of a distant cousin of Scott. We have the UCSF pedigree. I was trained in part by, actually, by Tom Boyer, who was at Emory at the time, and also Mel Wilcox also was UCSF trained. So sort of consider myself UCSF lineage. And many friends. I've known Tom Schiano for nearly 20 years and have made about a 2-day trip in 2000s to learn about living donor liver transplantation when you guys were going great guns. And Joe and Javad are part of Dylan Network, and Andrea, we worked on a grant together, put a great grant. Doug, many years ago, invited me to speak at one of your symposia at the time, and I enjoyed. And Mina helped us with a DSMB for the TREAT Consortium. So really, as you said, a lot of great friends here, and truly an honor to be speaking here. So this is my disclosures. Sorry, over the years I've gotten corrupt, and the two diseases I study are in demand at the moment. One is drug-induced liver injury, drug safety complications, therefore happen to serve on DSMBs, and the NASH, of course, is quite popular. This is some of my research support, and I don't serve on any speaker bureaus. Considering that there is a mixture of audience, some scientists, some fellows, I've had somewhat a challenging time to put the talk together. So you will see some overview and some thoughts about how to monitor for DILI in drug development. Some discussion about paradigms, how industry is screening their molecules, preclinical space, to see which are safer to go into humans. Some interesting stuff, and some work we're doing with Paola, who is in the audience here, about the genetic risk factors. This is through Dylan, and a few other things I'll walk you through. There are about 60 slides, so I may have to zip through some here. Why is DILI significant? It is the most common cause of acute liver injury in the United States, and this continues. This is a common reason why medications are withdrawn from markets, and also why the compounds are abandoned during drug development. Shown here, compounds that have been withdrawn or been put restrictions on. We all know troglitazone in mid-90s. This is Resolin, led to many deaths. Bromfenac, trovafloxacin, so on and so forth. More recently, tolvaptan, which still is available in the US for hyponatremia, but it was did not get approval for polycystic kidney disease because of hepatotoxicity. And obeticholic acid has a black box for hepatotoxicity in patients with decompensated liver disease. And then there are many examples of non-approvals and abandonments. And I had participated in Lilly's glucagon receptor antagonist, as well as peglispro, basal insulin. When a compound fails in phase 3 or phase 3 by then, company has spent about 10 years worth of investment and close to $400 billion. These two compounds failed. These are Lilly diabetes compounds. Both failed in the span of 2 years, and the estimation it costed them $1 billion. And people, once they failed, the people just retired. They just couldn't handle anymore. So dramatic impact when it comes that far and the compounds fail. And ulipristal is very interesting. This is, when you think you know about DILI, this compound shows up. This is also called Esmia, and this is not approved in the US. It is available in Canada and Europe. This is for uterine fibroid bleed. This is given in microgram doses. And this is a progesterone receptor antagonist. There are no progesterone receptors in liver, yet this caused acute liver injury, liver failure, some deaths. Fortunately, FDA is not approved. This compound may be somehow salvaged, but very interesting. So that also is a big failure. Now, still this is available in Europe and Canada, but with tight restrictions, can only be given for 3 cycles and with tight monitoring. So the most of my talk will be about idiosyncratic hepatotoxicity, just to set the stage. Direct hepatotoxicity is when you take a direct hepatotoxin. You take enough dose, you get a reproducible liver injury. Whereas idiosyncratic is unexpected outcome, it is rare, it is generally thought not to be dose-related. What I mean generally not dose-related is if you overdose with a compound, like for example, amoxicillin clavulanic acid, you're not going to get DILI unless you're genetically susceptible. Whereas direct hepatotoxicity, the one I talk about is acetaminophen or some other chemotherapeutic agents. If you overdose, you get liver toxicity. That's not the case with idiosyncratic. Idiosyncratic DILI can have multiple phenotypes. You know, acute hepatitis, cholestatic hepatitis, cholestasis, benign cholestasis, nodular regenerative hyperplasia, so on and so forth. So the point for trainees in audience here, when you see a new onset liver disease, always keep in mind, especially chronic hepatitis, people are coming to you with no clear-cut diagnosis. Always get good history. I've picked up hydralazine-related hepatotoxicity, methyl dopa, nitrofurantoin. You just have to keep open to this possibility. Etiology is generally unknown. One of the problems is there is not a good animal model that makes it very hard to study this disease. And it clearly has been a challenge both for clinical and basic research. So this is how you define DILI. If you go 25 years ago, DILI was defined as ALT twice upper limit of normal. That is just way too frequent today because of NAFLD. So this is a consensus definition published by a group of investigators. Guru Aital was the first author, and where you now need 5 times upper limit of normal of ALT, or doubling of alkaline phosphatase, or increase in total bilirubin. Keep in mind, in the absence of a competing etiology. Okay, so a lot of the primary care physicians send patients to us with statins, DILI. Actually, turns out ALT is only 105. Technically, it is not DILI. Okay. So I think one of the fellows had shown this list this morning at the fellows debate. By the way, was fantastic. I really enjoyed. Just to give you the common classes on your left and the individual agents that are responsible for DILI in the US. Antimicrobials account for up to 50% of all DILI cases throughout the world, as a matter of fact. This is the case from Latin America, Europe, and the US. And it remains a bit unclear why antimicrobials account for such a high proportion of DILI cases. This may be a function of the dose that you take, or could be some endotoxin priming. Nonetheless, that is the most common. And the second is the herbal and dietary supplements. Jawad, who's sitting in the audience, is working on this as well, and the DILI, Drug-Induced Liver Injury Network. And the other classes are described here. Shown here, amoxicillin clavulanic acid is by far the most common cause of DILI in the US, in South America, as well as in Europe. Not so in Far East. And the culprit seems to be clavulanic acid. The typical signature is cholestatic injury, and the mortality is not very high unless the patients have some underlying severe comorbidities, isoniazid, and so on and so forth. The point here, though, of top 10, 9 are antimicrobials. And the 10th one that barely makes it is diclofenac. Something very interesting about diclofenac, I don't think there is any mortality that we know from diclofenac DILI. So that's very interesting. There are a lot of compounds that cause severe liver injury, but mortality is somewhat is sort of specific to some compounds. When you have severe liver injury from isoniazid, there is higher mortality than, for example, severe liver injury from nitrofurantoin or from diclofenac. It's important when you see a DILI case of DILI to classify them into either hepatocellular or cholestatic because it helps you in putting together a signature and link it to a compound. For example, isoniazid always causes hepatocellular injury, whereas amoxicillin clavulanic acid causes cholestatic. That sort of helps you in, especially when somebody is taking multiple compounds. That's one. Number two, it sort of tracks prognosis. If you have hepatocellular liver injury, more likely to have acute liver failure, whereas cholestatic, not as much liver failure. Still, you can have high mortality. And then there is an entity called mixed, which is in between. Our ratio is what you use, but as clinicians, you really don't have to do that. You can just eyeball the liver tests and say, this is hepatocellular, this is cholestatic. When you see mixed injury where both AST, ALT, as well as alkaline phosphatase are high, not many things do that. So I think you always have to think about idiosyncratic drug-induced liver injury for a mixed type of injury. And this is a table that shows outcomes of different types of DILI, hepatocellular and cholestatic, but death or transplant about 11 to 12%. This is from the series that we published. The point, though, is if you have cholestatic, liver transplant is rare. But very interesting, nobody really studied this, is mixed injury seems to do much better than hepatocellular or cholestatic. In our series, 0% of mixed injury ended up requiring a liver transplant. Really puzzling why that is. Just a word about how do you attribute causality. It is a diagnosis of exclusion. Even when you're sure this is DILI, oftentimes you are stumped because there is something else that comes up. In the two papers that we published from Dylan, acute hepatitis C, Dr. Jawad Ahmed has published a paper recently showing that there are even cases that look like bona fide DILI, unexpected acute hepatitis C is there. So guidelines now recommend that for hepatocellular DILI, you have to get hep C PCR, just not the antibody. And as of today, there's not a specific test. There are some biomarkers, but they're not really good, and they tend to be non-specific. So some terminology, now I'm moving into clinical trial development space, some terminology that drug developers and regulators use: Hy's law, temporal corollary, and this ALT 10 times upper limit of normal. Hy's law is named after Dr. Hy Zimmerman, a pioneer in the field of hepatotoxicity. What he observed is when he was studying isoniazid hepatotoxicity, as long as patients had just increases in aminotransferases, they could be as high as 2,000. If the bilirubin was normal, they did not die. Whereas if the ALT was high and if there was an increase in bilirubin, then all of a sudden you're talking about severe liver injury, and they carried risk of mortality. That sort of later on morphed into this Hy's law, which is heavily utilized by the FDA during clinical trials to see if there is any signal for hepatotoxicity. Today's definition is 3 times upper limit of normal either AST or ALT, doubling of bilirubin, normal alkaline phosphatase in the absence of a competing etiology. If you have a Hy's law case in a clinical trial, if it is a non-cancer drug, that's a major liability, very tough to get through the FDA. Ximelagatran, which was approved in Europe and in UK, only reason FDA did not approve it is because they were studying it. There were cases of Hy's law. They were concerned and they were doing due diligence. Meanwhile, Ximelagatran started to cause acute liver failure in England and they had to be withdrawn. So that's the Hy's law. Really, if you're in clinical trial space, this is an important thing to know. Next is called temporal corollary. Basically, Bob Temple, who studies drug safety at FDA, after monitoring a lot of trials, he said just about all compounds with hepatotoxicity in clinical trials, they caused ALT increases. There is an imbalance. 3 times upper limit of normal, imbalance between active group versus placebo. This is very sensitive but not specific. The case in point being statins. They cause ALT increases, they don't cause liver failure, serious DILI. So you can have it, but that doesn't mean you're going to end up with severe DILI, but this seems like the prerequisite. There are not many examples. Even the ulipristal, the fibroid compound, when we look back, there is an ALT signal. It wasn't picked up because there was not adequate scrutiny. So that's an important thing if you're doing clinical trials, this imbalance. And then finally, this ALT 10 times upper limit of normal. This is in a clinical trial, if you see ALT 10 times upper limit of normal, it is, and if there is no other cause, it is truly an important thing. And there is a relationship for every 10 cases of 10 times upper limit of normal. If you have a large enough population, there will be one Hy's law case. So when you don't study a large enough population, FDA uses these logics and deduces. If you have one case of 10 times upper limit of normal, they'll think if you have large enough population, you would have 0.1 Hy's law. Then you would have 0.01 acute liver failure. So these are things that you look in drug safety space, okay? And you may have seen this E-dish plot. This was Dr. John Senior, who is another pioneer in the field from the FDA, built this E-dish plot to look in a clinical trial whether there is a signal for hepatotoxicity. Plotted on x-axis is peak ALT, and plotted on y-axis is peak total bilirubin times upper limits of normal. You have 4 quadrants. This is the quadrant that worries you. That means that you have not only ALT increases, but also you have an increase in bilirubin. This is the Hy's law. Whereas this is the temple corollary. If you have an increase in ALT, but bilirubin is normal, especially when you cross 10 times upper limit of normal. Another beauty of this E-dish is you can see placebo versus active treatment, okay? So generally speaking, this is sort of where you see a lot. Previously, this upper left quadrant, this is the cholestasis quadrant, got a free pass from the industry. But after obeticholic acid, now this also is getting attention. If you have an underlying liver disease, not only this quadrant, even the cholestasis quadrant is important, because a cholestatic insult in a patient with cirrhosis is equally bad. Okay? Just moving on to some compound-specific characteristics. So if you look, so in sort of 1990s, an immunologist from Toronto who was studying Jack Utright, who studies DILI, he observed that of all the compounds that have been withdrawn from the market, there is not a compound that's given at a dose under 10 milligrams per day. He said, is there a threshold? This is what he started to do. So this is a study we have done. Craig Lammert, who is now a faculty member, really highly successful, was a medical student at the time. We looked carefully at multiple databases to see if there is a signal between daily dose of a oral compound and the risk for DILI. And we were surprised to see there was a clear-cut signal that 50 milligram dose is sort of the threshold, the bottom. And this was a publication in Hepatology. This was subsequently reproduced by many other groups. And we all have seen patients are on stable doses, let's say, of azathioprine, and you escalate the dose, boom, the DILI comes. The same thing with, with statins and azathioprine, and we also have reported duloxetine. This started to tell us that maybe not, idiosyncratic DILI is not entirely dose independent. There is a threshold, and that there may be some dose relationship for some compounds. And then in a subsequent paper, Craig was interested to see if compounds with hepatic metabolism are more hepatotoxic. When I was finishing my fellowship, there was just a lot of talk. Is compound metabolized by liver? Then there is hepatotoxicity. When you look hard, there wasn't any literature. And so in this study, what he was able to show is if a compound has hepatic metabolism defined as at least 50% of the compound is metabolized by cytochrome P450 phase 1, then seem like there is a hepatotoxic potential. Then when you combine here, if a compound is given at a 50 milligram dose and is hepatically metabolized, then the compound is more hepatotoxic if you don't have either of the attributes. This is sort of what we called a rule of 2 to identify some compound-specific liabilities, hoping that the industry would be selective in choosing the doses and also whether it is hepatically metabolized or not.
Is the mechanistic thinking that when you have something that's metabolized by the liver, the intracellular concentration is higher, or B, that because you have enzymes acting on the drug, you're more likely to have adducts? Or what is thought to be the connection between hepatic metabolism and this susceptibility?
I mean, a couple things that's a really question, though, is the reactive metabolites. For example, the classic story is the acetaminophen and NAPQI, very reactive metabolite, and also adducts. That's one theory. The other one is Some enzymes are very leaky, cause oxidative stress. So those are two things. But it's beyond doubt today if a compound is 70% metabolized by cytochrome P450, and if you have a dose of 100 milligrams, it's just a matter of how much you use, you're going to get hepatotoxicity, especially in genetically predisposed. And this is a rule of two. FDA, after we have done our work, FDA has looked at this liver toxicity knowledge-based benchmark database, and they've done some work. And what they were able to come up is their rule of two. One is a dose, once again, but they used 100 milligrams. Also, this how lipophilic the compound is. Lipophilicity is defined as this octanol water partitioning coefficient, log P. And apparently in drug development, the log P, the sweet spot is 1 to 3 range. So in Chen's work from the FDA, if a compound has lipophilicity over 3 log P and also is given at a 100 milligram dose, oral dose, then the likelihood of hepatotoxicity is high. So these are sort of important because now toxicologists who are generating compounds or screening are looking for compounds without these characteristics so they can be moved forward to drug development. And then the same group, this is Chen's group, went on to do rule of 3 here, the same thing, a daily dose log P3, but also reactive metabolites. If you have those 3, there is and based on these 3, they used a logistic regression equation. They have a DILI score. And based on that, you can say how severe the DILI injury is. But this is sort of interesting. And one thing I want to point out, though, in the last 5 years, it's become very clear, exposure is very important. This is sort of what we're saying as a dose. Now, actually, the exposure Cmax and the plasma concentrations are now relating to drug-induced liver injury. These are 2 data sets. One is for Genentech and AstraZeneca. The other one is Pfizer. What you see here is the plasma Cmax had an AUC of 0.78 to predict a compound's liability. And here, if the Cmax total is more than 1 micromoles, that is where the risk sort of starts. And then in another study is 1.3 micromoles. I think, though, generally speaking, if a compound Cmax is more than 1 micromole, then I think you're going to carry some risk of hepatotoxicity. This is new compared to 10 years ago. We were not thinking idiosyncratic DILIs has any relationship to dose, but this is turning out to be not the case. And there is another thing called this biopharmaceutics drug disposition system class called BDDSC. Once again, there are 4 classes, class 1, 2, 3, 4, based on solubility as well as amount of metabolism. Once again, the right upper quadrant seems toxic. And we have done some work. I'm just giving these if you're in drug development, if you are advising a company, also just not about the efficacy, please pay attention to safety. You can look at some compound characteristics. Ask something like what dose it is being given, how is it is metabolized in terms of BDDSC classification, which quadrant it belongs. So I think you can educate many drug developers. They're not into safety. They're just stuck totally on efficacy. So now the toxicologists are using parametric approaches, basically a lot of different things put together and come up with a compound's liability. But the problem, though, is they are highly sensitive, not specific. So when I was talking to one of the Genentech toxicologists, really very eminent person, they worry that for every 1 positive signal, they may have as many as 9 false positives. So they would be screening out really other excellent compounds, especially for rare diseases. So this is sort of like a carpet bomb at the moment. So these are a slide that's showing for each of these reactive metabolites that says highly predictive for preclinical IDILI risk. There are a number of papers that just says it's not good. The point is still there is rule of 2, rule of 3. One thing you may see when you read literature, BSEP, which is the bile salt exporter protein, is an important modifier of DILI risk. If you have a compound that inhibits BSEP, it's an efflux protein. What it does is it makes bile salt accumulation in the hepatocytes, and they're toxic. You will see that. This is another thing. If you have a compound that is BSEP inhibitor, that's something you don't want in clinic. Okay. For example, bosantan, which is used for pulmonary hypertension, is a classic BSEP inhibitor, and it is obviously hepatotoxic to some degree. Just a slide or two on this DILI. So DILI-SIM is a company that has in the simulation models. This serves drug developers. What they do is, this is really interesting because they take the exposure data and the in vitro mechanistic based on the compound, because when drugs are being developed, the companies do a lot of these in vitro things, and they create a profile about this compound. Is it inhibiting certain things? Is it producing reactive metabolites? What is the mitochondrial toxicity? And then based on that, they can simulate and they can tell whether this compound has a liability or not. This is still in work in progress, but you may see that the compound has gone through DILI-SIM, and it has a liability or no liability. Paul Watkins is one of the advisors on this, and this is based in North Carolina. So when I was educating myself about DILI-SIM, something very interesting I learned. So we all have seen patients get increases in aminotransferases, but they don't go very far. They adapt to it. There is tolerance. And there are some patients that, boom, they get into liver injury. So this adaptation is being an intrigue for people in the field. And this DILI-SIM group seems to think the adaptation may be related to mitochondrial biogenesis. In other words, in patients that have just an ALT but not serious liver toxicity, either the mitochondria either growing, or they're getting bigger, or there is mitochondrial biogenesis in size. In vitro, they have some data to show here, valproic acid, both the mitochondrial protein increase both in vitro as well as in animal work. But this is sort of an interesting, I've not seen any human data, but this sort of explains, we have sort of struggled why some people don't go on to develop. They can go as ALT as high as 1,000 and never budge their bilirubin. This could be the mitochondrial biogenesis could be the source why some people behave better. So we're talking about moving from compound-specific risk to genetic risk, the host susceptibility. Last 15 years or so, there's been tremendous work in the space of genome-wide genotyping, also some whole exome sequencing. Paolo Nicoletti sitting here has worked in the space as well. So the biggest hit has been this flucloxacin, which is not used in the US, but is a popular drug in UK. And this HLA-B class 1 antigen 5701 had an odds ratio of 80. And there was some age interaction. You know, if you're over age 65, 1 in 100 carriers as opposed to otherwise 1 in 500. This is by far the most striking hit, but this turned out to be not clinically useful because you need to screen 500 people to find one who is going to get true positive hit. And then outside of flucloxacin, amoxicillin clavulanic acid has multiple hits. These have been validated, both class 1 and class 2 antigens, as well as PTPN22, which I'll share with you shortly. But the odds ratios are under 10. Even when you add PTPN22, I think odds ratio is still about 8 or 9. And the minocycline, terbinafine, fenofibrate, all have been some of the observations made by the DILI network, but the effect size is small, which means that is interest but not clinically useful yet. Okay?
What about abacavir and B5701?
That is pretty
strong.
That is very strong, and that is some of the work in the HIV field. Now you use that for
Standard of care, actually.
now it is standard of care. Absolutely.
Everyone gets that before they ever get abacavir.
Yeah, and also beauty of abacavir is it's an important antiretroviral. You know, it's for many countries. In terms of amoxicillin clavulanic acid, you can stop using it. So it, sort of the gravity is different, but we are learning in this space. And this is PTPN22 DILI. Nicoletta, Paula is sitting in the audience, is part of the Dillon grant from Mount Sinai, has done a lot of work in this. So what basically happened is this PTPN22 is the only gene to date outside of HLA that is a risk factor for all-cause DILI across all compounds, but this is sort of more so for augmentin, amoxicillin clavulanic acid. And this PTPN22 is not a new variant. This has been described for example, type 1 diabetes, other autoimmune diseases. And for example, if people have known HLA risks, the class 1 and class 2, and then you happen to carry this PTPN22, the risk is doubled and tripled. So I think now you're starting to get a understanding of multiple risks, genetic risks lining up wrong for an individual patient, why they get DILI, at least from amoxicillin clavulanic acid. Next few slides, I'll show some of the unpublished data with the work we're doing. Once again, Paola is part of it. This is HLA sequencing and Bactrim. This is trimethoprim sulfamethoxazole. It causes an important type of liver injury. We used to see far more when the HIV was more active. This is very interesting. In people whose HIV is not well controlled, Bactrim trimethoprim sulfamethoxazole is far more hepatotoxic. Once their viral loads are low, the risk of toxicity goes down. Something about the viral and the interaction with DILI risk. So this is a study I'll walk you through, very interesting. These are not published yet. So in the DILIN, we had 82 cases, and we excluded some. We had 68 cases. These are bona fide cases. 58 were Caucasians, and 9 were African Americans. These are American blacks. And using eMERGE-1 controls, these are population controls. We just had the GWAS data. We imputed HLA, and here is the BioMe. This is your Mount Sinai database. We had 5,800 African American controls, and also here we imputed HLA as well. What we saw in the Caucasians is this class 1, this HLA B1401 was an important risk factor. Once again, though, but it's about a 5% frequency in cases as opposed to very, very virtually undetectable in controls. You have a nice p-value, but this is sort of the odds ratio, but it's about a 6. But it's not interesting, but it's not clinically applicable because the effect size is small and this is a rare allele. And then we saw a hit, this is STAR 3501 in African Americans. Once again, stands the correction for age, sex as well. So these are sort of interesting hits. In the same study, Paola and Yuju from Duke have done with Elizabeth Phillips, have done this HLA allelic clustering analysis to see how these HLA, some of these hits are clustering. What you see here is then you can compare the cluster frequency between cases and controls. What you see here is there's the clustering of 1401 and 1402 with odds ratio you can see here. So the doubling of the cluster frequency. And interestingly, of all the patients, 8 patients, we had all of them either 1401 or 1402. Okay, and the same thing you saw with some clustering in African Americans. Interesting though, even with fewer cases, like 9 cases, but if you build a strong control group, you can get meaningful results, especially if you have advanced informatic approaches. And Paola was able to get samples from Europe. We had 5 trimethoprim sulfamethoxazole DILI cases, and 1 of 5 had this 1401 hit. You know, you're not compared to population, this is high frequency. This is coming to about 10% in IDILI. This is Dr. Nicoletta's cohort, as opposed to it should only be about a 1% in controls. This is highly significant. So our observation has been validated in an external cohort. And then we look to see how common this 1401 in Caucasians and 3501 in blacks in other DILI cases, and they're not. You know, here what you see here is 1401. You don't see in other DILI cases, just only in Bactrim. So this is a Bactrim specific hit, both in Caucasians as well as in African Americans. Okay, and And just few more slides to show how informaticians can solve some of these interesting questions. Here, Yuju and Paola have done this amino acid analysis in 1401. 1401 is the class 1 where we found it to be significant for Caucasian trimethoprim sulfamethoxazole. Here, they're using some publicly available website. They looked at the amino acid sequences for all B alleles, and turns out the 0702 is the most commonly represented. So what they have done is they looked at the amino acid sequence for our hit 1401 compared to this 0702 to see how many amino acids are different. And there are 16 different amino acid sites were different between 0702, that is the standard, as opposed to the 1401. And they went on to do some really interesting work. Here they looked at instead of using 1401, they used the amino acid location as a risk between cases and controls. And they found these 6 are differentially expressed between cases and controls. And the AA97 location seems to be very interesting. All these 6 amino acid sequences are differential. They're enriched just in Bactrim cases. And I'll tell you in a moment why this is interesting. And then when she has done some of the control analyses, these top 3 hits seem to be independent when you control for 97. This is amino acid location 156, 113, and 116. So why is this important? Because these amino acids may be important for peptide binding in the HLA. We are working with David Ostroff at University of Florida. This is the HLA molecule. This is the 3D structure of HLA 1401. You can recreate if you have this variant where you would have this pit. And seems that the sulfamethoxazole nicely fits into that groove within the HLA 1401. And these amino acids are the anchors. So really sort of interesting. So when you have HLA 1401, you have certain amino acids differentially present, and they attract the sulfamethoxazole. The same thing you don't see with trimethoprim sulfamethoxazole. We have done a similar exercise with minocycline. So this sort of adds sort of an interesting angle. You can go from a bedside into in vitro in silico modeling to see how you can explain some of the risks using these very sophisticated informatics and other modeling approaches. So that's about the drug development. The second half of my talk, I'm just going to talk about DILI in chronic liver disease patients. Any questions, though? How am I doing on time?
20 minutes, 20 minutes.
20 minutes, okay. So as hepatologists, one of the things that comes up always is DILI more common in patients with liver disease? If DILI were to happen, is it more toxic? How do you do causality? When somebody is developing compounds for liver disease, is there a different way you develop the compounds? These are sort of interesting questions. This is part of the Zimmerman lecture that I gave at the liver meeting. So there are a lot of compounds, if you look in the literature, that are thought to be hepatotoxic. But if you look hard enough, the data are not as strong. For example, I accept tamoxifen in patients with NASH can cause more worsening steatohepatitis. Some of the others are not as clear cut. This is a classic example. This is a highly quoted study, Wong et al. Now almost 20 years ago, showing if you have underlying hepatitis B, you're at a high risk for DILI from isoniazid. But the bottom line, though, is that the definition was not, today we would not accept the definition, 2 times upper limit of normal. And then furthermore, the cases in that paper had suspected DILI. They all had increases in hepatitis B DNA. So it's clearly acute hep B, but yet this sort of became the basis to say if you have underlying hepatitis B, you're at a higher risk for isoniazid hepatotoxicity. Point I'm making is this area is pretty messy. And the same thing about heart. If you have hepatitis C, you're at a higher risk for highly active antiretroviral therapy. But once again, people have said this is immune reconstitution. So once again, this is not as clear cut. So these are some examples where I think there is good evidence. Tamoxifen, if you have underlying liver disease, amiodarone, we discussed this morning, obesity and alcohol are risk factors. Methotrexate, I think we know that. And irinotecan, which is a colorectal cancer chemotherapeutic agent, which certainly obesity is a risk factor. And stavudine is also, if you have underlying liver disease, that's also a risk factor. Recently, as I said, the peglispro and glucagon receptor antagonists were withdrawn from the market because they both cause hepatic steatosis. PNPLA3 was a risk factor. If you carried PNPLA3, drug-induced hepatic steatosis happened more so in this clinical trial. This is a study that we published 15 years ago. When I was a younger faculty, we would get a lot of consultations about, patients have elevated liver tests, can you take statins? Not take statins. This is a study we have done to show if you have abnormal ALT at baseline, the risk of hepatotoxicity is no different than if you have normal liver tests. And after this study, many other studies have done to show the same, have come to the same conclusion. Bottom line is, at least from statins, same thing with glitazones. If you have underlying liver disease, you're not at any higher risk for hepatotoxicity. That's been the prevailing dogma, that if you have underlying liver disease, except for some compounds, you may not be at a higher risk. But though I've gotten interested in studying is NAFLD a risk factor for DILI. This is a study that we just published in Clinical Gastroenterology. Craig Lammert, once again, now as a faculty publishing. Using our health information exchange, this may be of interest to you, Andrea, using some informatic tools, we constructed a chronic liver disease group, which is sort of a quasi-NAFLD. These patients are obesity, diabetes, elevated liver tests, and there are no other etiologies. And we had 2 control groups. And then we looked at these patients and we received our top 10 hits from the gastro paper I just showed you. And we looked at possible DILI. To our surprise, though, is patients with quasi-NAFLD had about a 6-fold higher risk for DILI compared to 2 control groups, and about odds ratios 4 to 6-ish. And this was a surprise. When you looked in the literature, there's a paper from Italy many years ago. We all laughed at it. Also said the same thing. This is Tarantino's paper. NAFLD was strongly associated with DILI, about an odds ratio of 4. And there is a lot of a mechanistic basis to suspect NAFLD. There is increased reactive oxygen species, TNF-alpha, ER stress, mitochondrial dysfunction. If you talk to somebody who studies transporters and drug metabolism, they swear by it. They say NAFLD is a risk factor for NASH. The only word of caution, though, is that in the clinical trials we have done, we have not seen a great signal across NASH. Some compounds have hepatotoxicity, but we have not seen across all clinical trials. Dr. Friedman is a participant in many trials as well. We already touched on increased exposure. This is worth discussing. When the direct-acting antiviral agents were going through review process, they identified, this is the FDA as well as the AbbVie company, noted the Vicura was associated with liver failure. And as you know, this is a combination of these 3, Ambitsovir, Paritaprevir, and Ritonavir. And turns out in patients with advanced liver disease, the Paritaprevir exposure availability is significantly higher. Especially look at here, if you have a Charles class B, the Paritaprevir bioavailability is higher by 62%, whereas if you have Charles C, is about 1,000% increase. And most of the toxicity happened in these advanced liver disease patients from Vicura. Similar phenomena was observed with the Zapatir as well, where the Grazoprevir exposure was significantly higher in advanced liver disease. So I think everything is coming together, that the exposure is important for idiosyncratic DILI, and then patients with liver disease will have exposure, increased exposure, especially if it is a hepatically metabolized compound. And the obeticholic acid, which is now approved for primary biliary cholangitis, post-marketing, there were about 19 deaths and 11 other cases of serious liver injury. Bottom line, once again, though, a couple lessons from this. Once again, this is related to dose. In advanced cirrhotics, when they were taking 5 milligrams every day, that's when most of the toxicity happened. Now the black box says 5 milligrams once per week in decompensated liver disease patients. That's one. Number two, this is the first instance that I know a cholestatic injury caused deaths. This is causing cholestatic injury, but it is happening in the background of underlying liver disease. That was enough to cause deaths and liver failure. So this is really a great illustration of even a cholestatic injury in an underlying liver disease patient can be bad news. This is data we published showing if you have underlying liver disease, the mortality is from DILI is about 4 to 5-fold higher. We saw in the study azithromycin enrichment. I'm not quite sure. This is a data that is under revision showing not all liver disease is created equal. If you just have a mild liver disease, you're not at any higher risk for worse outcomes. But if you have moderate to severe liver disease, odds ratio is 4.6 compared to patients with no liver disease or mild liver disease. Okay? And this is a slide that Hoofnagel put together. Once again, they're showing the same thing. If you have pre-existing liver disease, the risk of fatality is significantly higher. I think not a surprise because of reserve is not high. They won't tolerate it. Last few slides. This is work is under revision. We've been very interested recently in comorbidity. Some of the clinicians will like this. So, so we had patients who are 65, 70, COPD, oxygen. They get an augmentin, DILI, very mild, yet they don't recover. They die. Whereas you have a 25-year-old, really horrible isoniazid hepatotoxicity, make it through. Starting to wonder, if the comorbidities are an important determinant of outcomes. So we have done this study, really worked out quite well. We had 306 patients that we enrolled in DILI at IU site. We have done this Charlson Comorbidity Index, and then we developed a model. We validated on the University of North Carolina cohort. They had about 250 patients. And the CCI, this is a score, turned out to be very predictive of outcomes, more so than MELD. In our multivariate analysis, 3 things fell out. One is the Charlson Comorbidity Index, MELD score, and the third being low albumin. And some of the C statistic for ROC curves was quite high, 0.9. This is spectacular. If you think about MELD score we widely use, its C statistic was like 0.78. This is 0.9 is pretty robust. And then the same thing in the validation cohort as well. So this is the CCI more than 2. This is sort of the 75th percentile in terms of comorbidities in our cohort. You could see how nicely they separate. And this, when we apply this to UNC cohort, it looks exactly the same. What we were able to do is to construct a nomogram. This will be available it's a web calculator, would be available via internet. So based on albumin, MELD, and CCI, these are the points, okay? For example, somebody's albumin is 4.2, they get 10 points, MELD score, you can use 2. And then you can total, based on the total points, you can look at the risk of death here. And this validates quite nicely on UNC cohort as well. So this is for patients with suspected DILI. Today, if you have a suspected DILI patient, all that you have today is MELD score to tell you. But that turns out not as good compared to adding the CCI as well as the albumin with this nomogram. And this is under revision at Gastro. Hopefully it'll get published as well. So just to summarize my talk, though, take-home messages are, I think over the course of last 10 years or so, we are picking up compound-specific risks. This include daily dose, how lipophilic compound is, how hepatically metabolized it is, ox, stress, reactive metabolites, also effect on different transporters, especially the BSEP seems to be the important transporter. And the genetic risks are largely limited to HLA, although we are picking up some PTP and 22. Hy's law, temporal corollary, ALT 10 times the upper limit of normal. If you're in the clinical trial space, if you're a clinical trialist, these are the things that you should know. And there is a potentially NAFLD is associated with increased risk of DILI, but I think we just need more data. And the concentration-related, Cmax-related hepatotoxicity is a revelation within past 6 years or so. As you saw, if the Cmax is more than 1 micromoles, that's when I think you need to start worrying about. When I'm doing consulting, this is sort of what I look for to advise the companies. And the DILI, both hepatocellular as well as cholestatic, is bad news. Although, for example, anabolic steroids, they cause bilirubin up to 30 to 40, but they never really cause any death. So especially cholestatic is bad news if you have underlying liver disease. And I think that's my last slide. And I thank you for your attention.
The most comprehensive, understandable talk on the topic I've ever heard. It's fantastic. Questions? Gene?
Dr. Chalasani, thank you for a wonderful talk. A common scenario that we see is very mild suspected DILI. This patient is overweight as well, ALT 70s from a drug that has a signal for DILI. Now we have non-invasive tests to assess for fibrosis and see maybe the significance of this sort of chronic DILI. How long can we get away with sort of watching these patients if it's a medicine that's really important, if their fibrosis scores are low? Is there a potential for an improvement given the data you showed with like mitochondrial reactivity perhaps? I mean, how do you approach those kind of
I recently saw somebody who is an antipsychotic, really needs it, but has a mildly increase in ALT, about 100. And I'm just doing what exactly you're doing. I'm monitoring him, and I sort of recently coined this mini Hy's law, which is increase in ALT 3 times, but doubling of direct bilirubin, and also going beyond 0.4. That's sort of what I watch for, as long as the bilirubin is not budging, and if it is not going to 10 times upper limit of normal, but if the patient is educated, understands, the family understands, and I document well and I'm following. And of course I do periodic fibroscans to make sure that they're not ending up. I have probably 50, 60 patients on statins. They go up and down, and they're there. Sometimes they get better. It's not been a problem. I haven't had any, in my own hands, a statin, major liver injury.
Mina and then Andrea.
So you mentioned kind of NAFLD as a predisposition to DILI. What I've observed, and I've not studied it, but like any insult, their liver enzymes just go higher. So for example, someone with underlying NAFLD gets Hep A, and they can have AST and ALT that is just much higher than you might expect in someone who doesn't have underlying NAFLD. So I wonder if that's just the same thing that you're seeing, is that the numbers go up so that you're qualifying them as DILI, but it's not just unique to drug-induced liver injury.
It's a good point, though. It's a similar thing we observed with hepatitis C. When they get Gall's CBD stones, it's not ALK-Phos that goes up. Their ALT goes into 400 or 500s. And I think the patients with this chronic liver disease, they're probably hepatocytes are trickly, and then they just release. And also in NAFLD, there is this theory, ALT increases more increased transcription. You're synthesizing more ALT rather than leaky membrane, et cetera. So your point, that was one of the criticism, just you're seeing ALT, but we had a trend for mortality as well. So I think they may be real. But this is totally epidemiological study. The best you can say is we are seeing a signal, nothing more than that. But just sort of for toxicologists, they sort of like this, because this is what they've been saying for about a decade now.
Andrea.
I wonder if you could flesh out your thinking a little bit more about how you look for genetic susceptibility. So you mentioned we see these associations, but the effect size is too small to be of great interest, and the genes are rare. So is there sort of a cross point of effect size and prevalence that you use in your head to figure out that this is something of interest? Or how do you get that balance between prevalence and effect size? And is there a kind of a minimum effect size that you want to see before you would kind of get excited about a genetic susceptibility?
I mean, I think double digits odds ratios, and I think Paola may be better suited to answer that. But what do you think? Double digit odds ratios?
Yeah, I mean, as a rule of thumb, I would say that, but the higher is the odds ratio, the better. So the problem of the pharmacogenetic testing is always this, especially for DD, a serious acute reaction. So sometimes we have to test a lot of patients, and the fact that you are positive for the test, although you are positive, but the probability of getting a reaction is not very high. So
The clinical application becomes,
so
you know-
it's not useful clinically
Yeah.
because you have to. So basically, we have to make an effort to even screen why, if you are positive, why you get the reaction or not get the reaction. So over there, we have to really dig into. So, for example, abacavir is like a textbook example, but for fluoxacillin, so the odds ratio is very high, but we have 1 cases of DILI out of 500 positive
Carriers.
sample positive patients.
I see.
So we have to really dig into which are within the positive. Why only one patient got the reaction versus the other? So if we will able to narrow down that,
think
and of
the-
course, by the fact,
in terms of the direction, Andrea, is as we are, this is once again, not only to me, Jay Hoofnagel, et cetera, the one that are funding the DILI, as our sample size is growing, amoxicillin clavulanic acid, we are picking up, for example, PTFPN22, and then using some novel tools, ERAP2 was found as well. So I think as there is more sample size, you will get multiple hits, and then there may be a polygenic risk score. But the disappointing thing is this is turning out to be compound specific. This is not one score across all DILI. So then you have to choose, what is it worth it? Abacavir is worth it. Amoxicillin, clavulanic acid, flucloxacin are not worth it. You just go to next class. So, but I think it helps us to understand the biology.
I agree. No, and that's why it was really from that perspective that I was asking the question. I think it is interesting, biology.
So from the, one sec, Frank, from the point of tools, increasingly, we're going to see patients who have whole exome sequencing. Do you foresee, or are there any demonstration projects in which, rather than searching for that when you're ready to start augmentin or amoxicillin, you actually have the data in the chart that says, don't prescribe amoxicillin, this patient has a risk allele?
And I haven't seen DILI, but for example, there are, I'm sure Mount Sinai has a pharmacogenomic service as well. For example, before you start abacavir or before you start, azathioprine, et cetera, there are alerts, et cetera, but not for DILI, because I don't think we are there yet. But I'm sure you also have the Cancer Precision Genomics program. But this is rare enough, that's the problem. That's such a rare event. And the biggest value I see is salvaging compounds. For example, tolvaptan, the company is still trying to figure out, because it's not approved for polycystic kidney disease. That's the only compound there is for that disease. Yet it's not approved. They're seeing if there's a way that you could come up with risk factors, at least a subgroup can get it. That's one area where I see, but not in the clinic, but it's sort of more, getting compounds to market by, sort of stratifying risks.
Frank, final question?
Absolute rules always bothered me, just like when you get a ticket for driving 1 mile over. Are gender differences in enzyme levels considered in most of these studies? For instance, we use 40 usually as the cutoff, but in females it's going to be much less.
I know. That's why, though, I think the smart thing that the consensus statement has done is it's 5 times upper limit of normal. The assumption is that the upper limit of normal is adjusted for gender. So some labs do and other labs don't. That's the caveat. But at least that part is, it is not just an absolute 200 is DILI, but it is sort of upper limit of normal. So taking into that consideration. Old data said there is females that are higher risk for DILI. Turns out that's not the case. It is just happened to capture more in these registries. Gender is not necessarily a risk for severity of DILI, outcomes of DILI, and we haven't seen anything as a gender as a specific risk factor. But certain compounds you see more because you happen to be tamoxifen is largely used in women except for some rare mesenteric paniculitis in men. But
All right, okay, Amon, final question.
So just curious, as a hepatologist in the hepatology group here, are we doing a better job at checking for hepatitis E before we just call it potential DILI? Are you seeing more of an uptake for people referring to you to actually checking or doing a better job at checking hepatitis E?
I mean, there is a rare case of acute hepatitis C. There's a paper more recent paper that's also submitted. There's the Davern's paper that we published. I mean, it's just sort of, I think the practice guidelines says if some things don't line up. For example, we had a case of simvastatin DILI. It's a gentleman who was on simvastatin for 10 years almost. Came in with an acute liver failure, underlying cirrhosis. It didn't add up, but that's how we just sort of transplanted him. Later on, turned out it was acute Hep E. It's some Midwest. So those sort of things, when they don't add up, because there's not a commercially validated assay for Hep E. For us, Bob Purcell and NIH was doing it. But that's a problem. Especially some parts, you go to Turkey, UK, Hep E is a very important masquerader of DILI.
So join me in thanking Dr. Nala.